Hi, welcome everybody. Just let me know if you all can see me live. Great. So, welcome to another session of Medico Apps MCQ Live. I'm your mentor, Dr. Abhishek, and today we are going to take the third session of this particular series where we are discussing everyday MCQs. Before I start, if you are new to this channel, this is the first time you have tuned into this channel, make sure you hit the subscribe button and subscribe for the bell notification so that whenever I go live, you can get the notification. Give this video a thumbs up so that it gets stored in your like video history. If you have any questions or anything regarding this video or any suggestions regarding this MCQ series, any topic or any type of questions which you want me to take, make sure you write in the comment. And yes, if you love this session, I would request you to share to your friends. This session is inspired by a lot of feedback from which I got from my students. They used to say, sir, whatever you teach in theory classes, we keep forgetting. But whenever you take an MCQ class and whatever you have taught in MCQ class, we remember it in the examination hall. So kindly take more MCQ classes. So that's why we are taking this MCQ classes. And there is a small saying. I would like to start the session with that. Pothi padi padi jagmua pandit bhaya na koi, which means you can study volumes and volumes and volumes of theory. MCQ Gupta के साथ बनाए वो पंडित होए, which means if you solve MCQs with me, you will learn it and you will remember it and you will be able to use that information to solve MCQs in the examination. So without much delay, let's look at the first question for today. So this is a clinical case. The case is given as a 40-year-old male farmer came with complaint of upper right quadrant pain. Okay, there is loss of appetite and yellow skin and eyes for last 2 weeks. So he is giving a history of probable jaundice in last 2 weeks. Lab investigation shows elevated liver enzymes and bilirubin level. Later, he was diagnosed with hepatocellular carcinoma. So this is a very, very big clue. Okay, so 40-year-old. Now, hepatocellular carcinoma in such a young male, it's not very common. Okay, and we have not been given any history of alcohol or anything like that. So, uh, what so this is the history which have been given to you. And then they are asking which of the following fungal infection or fungal etiology can be suspected as an etiological case in this particular case. So we have been given Aspergillus flavus, Aspergillus fumigatus, Penicillium marnefidi, and Aspergillus niger. So all of you can write your comment. All of anyone can write the comment. So this is not fungal infection, but fungal etiology. So there is a particular fungus which produces a toxin which can cause hepatocellular carcinoma. So can anyone write in the comment which is that toxin, which is that fungus? Okay. So remember, we are talking about aflatoxin. Okay, and this aflatoxin is produced by Aspergillus flavus. So the correct answer here will be A. Before we move forward, let me talk a little about aspergillosis. So aspergillosis, causes three different types of infection. Okay, one is invasive aspergillosis. Second type of infection which aspergillosis or aspergillus causes is the chronic infections, and the third type of infections of third type of manifestations of aspergillosis is allergic. And very important is we need to know the three different types, because on one hand, for invasive aspergillosis, the mortality is as high as 100%. Whereas in chronic aspergillosis, we will see certain chronic aspergillosis, the mortality is 50%. And for allergic, aspergillosis, ABPHA, okay, the mortality is less than 1%. So this is why we need to know the three different types of diseases caused by aspergillosis. So what is aspergillosis? It is a collective term used to describe all the diseases by aspergillus. So there are three primary aspergillus uh, genus we will species we will talk about. First is Aspergillus fumigatus. Now fumigatus is causes ABPA, allergic bronchopulmonary aspergillosis, and it forms the allergic part. Okay. Second is Aspergillus niger. Niger. So it causes angio-invasive infection and primarily in a diabetic patient. So you will be given a diabetic patient history, and there suddenly there is a deterioration, respiratory infection and angio-invasive aspergillosis that will be there. And again, angio-invasive, remember, the mortality is very, very high, close to 100%. And the third is Aspergillus flavus, which primarily causes sinusitis, but it also produces aflatoxin, which gives which may cause hepatocellular carcinoma. So these are the three different types of you know uh, diseases caused by aspergillus, and that is why it is all these three are called as aspergillosis. Our next question is, what is aspergilloma? Again, very, very commonly they will ask and student get confused. So aspergilloma, also called as fungal ball, and is basically a fungal ball, and in pulmonary cavities which are more than 2.5 centimeter, they can form fungal balls. So that is aspergilloma. Another very important set of questions for aspergillosis will be the risk factor for development of aspergillosis. So remember, neutropenia, AIDS, leukemia, steroid, and even uh, infliximab drugs like infliximab can cause certain predisposing factors like TB, COPD, cystic fibrosis, asthma. Okay, so all these risk factors have been asked. Okay, so this is primarily about aspergillosis. This is a very, very high slide. Every year, or every alternate year, one question on aspergillosis is very, very commonly asked. Okay. So the correct answer in this case was Aspergillus flavus. And here history of a farmer. Okay, farmers generally will be using uh, produce from their field, and that produce may be affected by this particular fungus, and they may be chronically taking this aflatoxin, this leading to hepatocellular carcinoma. So let's move to the next question, guys. So this is the next question. Which of the following statement about diabetic ketoacidosis is true? So this appeared this year in NEET PG. This question came in NEET PG this year. So which of the following about diabetic ketoacidosis is true? And your answers are decreased bicarbonate, increased lactate, normal anion gap, and glucose less than 250. So if you are live or even if you are seeing the replay, try to type in the answer. Try to type in the answer. Okay, so this option is definitely not correct. The last option, glucose less than 250, because we are talking about diabetic ketoacidosis. So hyperglycemia, where blood glucose will be more than 250 milligram percent. Okay. Now, obviously, we are talking about ketoacidosis. So acidosis will be there, but will it be normal anion gap? No, it will be HAGMA, high anion gap metabolic acidosis. In fact, diabetic ketoacidosis is a very, very important cause of HAGMA. Okay, high anion gap metabolic acidosis. So this option also goes out of the window. Now you have got increased lactate and decreased bicarbonate. So let's consider for a moment. Okay, what happens in acidosis? What happens in acidosis? There is an increase in the H plus ion. Okay, now we know this equation for any acid. Okay, okay, right? So if there is an increase in hydrogen ion, the body will use the bicarbonate and try to neutralize the hydrogen ion by converting into H2O and carbon dioxide. So whenever acidosis is there, okay, metabolic acidosis is there, bicarbonate will definitely decrease. Tell me if you understand this concept or not. Okay, let me again reiterate it so that you are very, very clear. So we know this is the equation for your all acid base balance. Okay, we know bicarbonate represents the base, carbon dioxide represents the acid. So whenever carbon dioxide is increased, there will be acidosis. So in diabetic ketoacidosis, okay, so because it is an acidosis, hydrogen ion will be increased. Any doubt? So if this is increasing, the body will immediately use the bicarbonate which is already there in the body. Both of these will be combined. So body will try to neutralize the excess hydrogen ion, convert it into H2O plus carbon dioxide. This carbon dioxide will be, exhaled out. So there will be decreased in the bicarbonate level. So this answer is correct. Now increased lactate. So in diabetic ketoacidosis, there is no reason why there should be an increase. Lactic acidosis, there will be increased lactate, but diabetic ketoacidosis, there cannot be increased lactate. Okay. So the correct answer here is A. Any doubt in this? Any doubt in this question? So quickly, before I move forward, let's quickly revise the causes of high anion gap metabolic acidosis, also called as HAGMA. So we can revise or learn all the causes of high anion gap metabolic acidosis by a very, very commonly used mnemonic that is called as MUDPILES, mud piles. So M is methanol. So methanol poisoning will cause HAGMA. U is uremia. So CKD will cause high anion gap metabolic acidosis. D, we all have just studied, diabetic ketoacidosis will cause high anion gap metabolic acidosis. P, anyone? P. So remember paracetamol poisoning. Very, very important cause. Paracetamol poisoning, even propylene glycol. Okay, these two are very, very important causes. I stands for multiple, like say infection, okay, and even drugs like isoniazid can cause high anion gap metabolic acidosis. Then L is for lactic acidosis, HAGMA, okay. E is now ethylene glycol, and last S is salicylates, okay. So this again is a super important high yield topic which you have to remember. No chance you can forget it. So now once we have understood this, let's move. So which of the following statement is true about diabetic ketoacidosis? So we have seen this is definitely wrong, this is definitely wrong, this we are not, here. So decreased bicarbonate is definitely correct, and I have showed you, or I have given you the explanation related to this. Another question which appeared this year on diabetic ketoacidosis was this. So cause of death. See, the question is cause of death in diabetic ketoacidosis in children. And your options are cerebral edema, hypokalemia, infections, or acidosis. So what is the cause of death in DKA in children? Anyone can write? Anyone can write this, this answer? What is the cause of death in diabetic ketoacidosis patient in children? Okay. So let me take you through the pathogenesis or etiopathogenesis of diabetic ketoacidosis. Then you will know the answer very, very easily. So first of all, remember diabetic ketoacidosis as a complication, is it more common in type 1 or is it more common in type 2? Now remember, diabetic ketoacidosis is more common in type 1. Very important. What is more common in type 2 is another complication called as hyperglycemic hyperosmolar coma. Okay, so this is more common in your uh, type 2 patients. In type 1 patient, diabetic ketoacidosis is more common, and mortality has a direct correlation with the age, which means if the age is less, there will be less mortality, and with increasing age there will be more mortality. So what are the triggers of diabetic ketoacidosis? What causes diabetic ketoacidosis? So there are some triggers. So type 1 or type 2 diabetic patient will have some triggers, and these triggers may be mentioned in your examination as a clinical case. Okay. So what are these triggers? So trigger can be infection. So whenever there is an infection, what will happen? There will be increase in the requirement of the energy. Okay, because body has to fight the infection, and this will be related to the increase in the requirement of the insulin by the body, hence precipitating the diabetic ketoacidosis. Any other acute illness like an MI or a stroke or after surgery, again same thing. There's an increase in the energy requirement of the body and increased insulin, poor compliance of the patient, and increased insulin pump malfunction. So these are the 4 5 very important triggers of diabetic ketoacidosis. Let's look at the pathogenesis. So there is a metabolic trigger which essentially says either the insulin energy requirement or insulin requirement is increased, or there is, the person has not taken insulin. Okay, so say there is some compliance issue from the patient's end. So what will this do? This will do two things. First of all, it will increase the glucose level, and it will also lead to the formation of ketone bodies. Okay. What will this increase in the glucose do? This will lead to osmotic diuresis, fluid shift or dehydration, and this further will lead to electrolyte disbalance. Any doubt till now? Now, what will ketone bodies do? Ketone bodies will lead to acidosis and damage the blood-brain barrier. And all these, so damage to blood-brain barrier, fluid shift, and electrolyte disbalance, all these will cause encephalopathy. And this is the major cause of death in the patient. Okay, so now once you have done it, you know, and whenever there is a diabetic ketoacidosis, there will be increase in the growth hormone, catecholamines, and cortisol. So once you have read this, you can very easily say that cerebral edema is one of the cause of death, one of the most important or most common cause of death in diabetic ketoacidosis. Okay, is this clear? This is primarily your trigger. Okay, acidosis component to a large extent is neutralized by the body bicarbonate reserves. So it generally do not cause, in fact, diabetic in DK patients, remember this very important fact. We do not treat we do not treat the acidosis till it is very severe, which means if the pH is less than 7.2, 7.3, then only we treat it. Otherwise, we don't even treat the acidosis component. So this is also wrong. Hypokalemia. So in diabetic patients, generally, hypokalemia will be happening when we treat the patient. Okay. Otherwise, there will be hyperkalemia in those patients. Okay. So the correct answer will be cerebral edema. Any doubt? Let's look at another clinical case. So here a 40-year-old male presented with history of hypertension. So this patient is having hypertension. He had abdominal pain and swelling in the lower back, very significant. On examination, BP is elevated, okay, and tenderness over bilateral kidneys. Okay, so bilaterally the kidney is, big, tenderness, hypertension. Okay, so what will be the and then you have been given a ultrasonography image, and you are asked about a diagnosis. So in the ultrasound image, we are seeing that throughout the kidney, small cysts are there. Can you make this out? Can you make the ultrasound? Okay. So what should be the answer? Autosomal dominant polycystic kidney disease, renal artery stenosis, chronic pyelonephritis, and medullary cystic kidney disease. Okay. So let's look at each of these options so that you are very clear. Now in renal artery stenosis, there is no reason to be have certain cyst, so many cysts which is present throughout. So this we can very easily rule out. Okay. Chronic pyelonephritis, yes, it can present with enlargement and tenderness. So, but there is no reason to have hypertension unless the patient is having CKD. So this, and again in chronic pyelonephritis, you will not have this studded cyst throughout the kidney. So again, this we can rule out. Now we have got two options: autosomal dominant polycystic kidney disease and medullary cystic kidney disease. Now, medullary cystic kidney disease, basically it's an again autosomal disorder, but here there is a I mean, the patient will not have such kind of even the location of the cyst is a very important clue, but here the general presentation is very slow deterioration of kidney function. That is the, so it's very uh, slow presenting disease, generally not diagnosed very early. Okay, so we will see, and here this typical case, so he is very old, young male, 40-year-old male with enlarged kidney and kidney having multiple cysts. So the correct answer will be autosomal dominant polycystic kidney disease. Let me quickly, take you through the locations of the cyst, and based on that, so this was the image which was given to us, right? throughout the kidney is very, very enlarged, and the cysts are throughout the kidney. So what will be this? So this will be definitely autosomal dominant polycystic disease. Okay, and here if you see in this, it's more like a striae. Okay, what is this? So this is autosomal recessive polycystic disease. Okay, here if you see, now in this case you can see it is at the junction of the corticomedullary junction. So this is basically your medullary sponge kidney. Okay, so medullary sponge kidney is a congenital disorder. Okay, and there is a cystic dilatation of the collecting tubule. It can happen in one or both the kidneys. Okay, and it creates again a sponge like appearance, and here if you see, uh, the kidney stones will be at the corticomedullary junction. Is this clear? So this is medullary sponge, and the last is, when you can see, is medullary cystic disease. Again, it's an autosomal disease, and here you can see the cyst. Okay, it is at the end here. Okay. So these are based on the location also, because ultrasound was given. So based on the location, you can easily identify, and based on the clinical case also, you can identify. So let me talk about polycystic kidney disease, because again, it's a very, very high topic. So there are two genes involved. So on, if you talk about the genetics part, okay. So first is gene is on chromosome 16, and the second gene is on chromosome 4. So chromosome 16, we have got PKT1 gene defect, and on chromosome 4 we have PKT2 gene defect. Any doubt? Okay. And here it is polycystin 1, which is the affected protein, and here we have got polycystin 2, which is the affected protein. Super high yield information, you have to remember it. So this is again a high penetrance but variable expression disease. Now, what do I mean by that? Which means from first generation to next generation, the genes will be passed. So it's high penetration. Okay. But let's say from the father, it was passed on to both the son as well as the daughter. But son may have may show the symptom at very early age, maybe at the age of 20 years, 25 years. But daughter, even though she is having the gene, but she will show it, she will be pretty normal till 40, 45, 50 years of age. So this is what I mean by variable expression. Is it clear? Very, very important. High penetrance means the gene will be passed on with very high frequency to the next generation. But variable expression means that even though two children will have the same gene, but they may be having different expressions. So some may be affected, even vice versa. The girl child may be affected very early, and the boy child may be affected late. So two siblings, one may be having very high expression, one may be having very low expression. Is it clear? So here, okay, so this is important. So how do they present? So if we talk about clinical presentation, generally the age of presentation is somewhere between 30 to 45 years of age. Okay, how do they present? So here, remember, the kidneys are going to be grossly enlarged. Okay, and there can either be stone formation, or even when the cyst, they bleed inside. So they can be, the fascia may be, the gerota fascia may be stretching. So they may present with abdominal pain. Generally, they will present with abdominal pain. Okay, and this abdominal pain can be due to the stone or due to the bleeding in the cyst. Okay, bleeding in the cyst. Okay, they may also present with recurrent UTI. So recurrent UTI again can be causes, and this may lead to pyelonephritis also. Also, I have told you what is the they present with recurrent stones. There is an increased incidence of stones. So what is the most common stones which is seen in here? Anyone? So remember, here the most common stone is urate. What is the normally most common stone? So here the most common stone is your urate stone. Okay, and remember, these patients have higher chances of developing renal cell carcinoma. Okay, renal cell carcinoma. So they have a very higher chance of developing renal cell carcinoma, which is bilateral and which is also multicentric. Okay, so renal cell carcinoma, higher incidence, but not only the higher incidence, in these cases there will be bilateral and multicentric renal cell carcinoma. And obviously there will be decreased in the GFR, there will be decreased in the GFR and increase in the blood pressure of these patients. Okay, and manifestations of the blood pressure, like headache and all, can be present. What they will generally ask you is, what are the extra renal manifestations? So that is where you have to, so what are the extra renal manifestation? So apart from liver, apart from kidney, where is the cyst? So remember, the second most common place after kidney is your liver. So liver also, you will have liver cyst, and you can also have cyst in the pancreas. You can also have cyst in the spleen. Okay, you can also have cyst in the spleen. So apart from your kidney, you will have cyst in the liver, you will have cyst in the pancreas, you will have cyst in the spleen. Okay, another very important, you can have perianeurysms. Okay, perianeurysms in these patients. So these patients uh, can have subarachnoid hemorrhage, sudden subarachnoid hemorrhage. Okay, so this is it. They can also. So what is the most common cause of death in these patients? Anyone? So remember, it will be generally hypertension related complications. Okay. So most common cause of death is generally hypertension related causes. Okay. The CVS causes will be generally cause of death. So this is polycystic kidney disease. Again, a very high yield topic, and you should know almost whatever I have taught you by and large, and it will be able to solve most of the questions. Let's look at another case. So here we know the correct answer is autosomal. In fact, the clinical case study of hypertension, abdominal pain, swelling is basically indicating your increase in the kidney size. Okay, and this image is very classical throughout the kidney. You have got your started with the. Let's look at this question. Common substrate for purine and pyrimidine synthesis are all except glycine, aspartate, glutamine, and carbon dioxide. So anyone? What are the common substrate for purine and pyrimidine synthesis? Just write in the comment. Okay. So let me show you both purine and pyrimidine so that you know. So this is basically pyrimidine, this is purine. So we can see glutamine forming part of both purine and pyrimidine. Respiratory carbon dioxide forming part of both purine and pyrimidine. And this portion is by aspartate. Here also, this nitrogen is by aspartate. So glycine is not a part of purine, pyrimidine synthesis. Is it clear? So the correct answer here will be A, glycine. Again, a very simple question, but I know synthesis of purine, pyrimidine, and metabolism of purine, pyrimidine again forms a very important part of your MCQs in the examination. Okay, so this brings us to the end of our session today, and these sessions, as I have told you, it's primarily to make you solve more MCQs on high yield topic, and whatever I'm going to tell you, that is the most high yield topics which will be asked in the examination. And another last thing before I leave for today is revision a challenge for you? And why is revision generally a challenge? Because when we revise, there's lots of information, 20 subjects, each subject will have so many pages of notes. Revision also is very boring. The moment you start revising, you feel like sleeping. And no matter how many times you have revised, you always seems to keep forgetting it. So that's why revision is very challenging. And for this, we have got something called as concept cards. So you can download the concept cards from our store on the Play Store. You can simply type Medico Apps concept card. You will get that app. You can download it. And what we have done is, first of all, we have not given you every information. It's just high-yield information. High-yield information which are very frequently asked in the examination. And again, we have not given you as a theory. We have given you those information as image or flowcharts, so that it activates your visual memory, and you are able to remember those flow charts in the examination, those images. Once you see an image and then you learn some theory about it, you will definitely, and you know generally these flashcards, they invoke active learning, which means it will not be just one image, but one image will have some question and the next image will have an answer, and then the next image again will have some question, and the image after that will be having answers. So it's not like you're just rereading everything. Normally what will happen when you revise in from notes, you're just rereading, and in the examination suddenly you realize, I read it but I forgot it. But here what will happen is, because every information is followed by some kind of question, so if you are forgetting that particular information, you will immediately know that this is the information which I'm forgetting. So it's basically focused on active learning. So this is Medico Apps concept card. You can go to our Instagram page, obviously follow us there, and you can simply what you call download the concept card. The download link will be there in the description of this particular video. And this brings us to the end of these three session, third session. Tomorrow there will not be a session, but day after tomorrow, the last session of this week at 4:30 p.m. Okay, so the same time, and then again on the last session on 21st April, I will give you the schedule for the next week sessions also. So please be there. And again, if you are new to this channel, this is the first video you have seen, just subscribe and hit the bell icon so that you get a notification whenever you are live, whenever I'm live. And you may not see the video at the same time, but later also, if it is in your notification, you will definitely see it. Give this video a thumbs up so that it gets stored in your history. And if you have any comment, any suggestion, any question, you can just write it in the comment, and I would love to answer it. Please do share this video with your friends so that they also know this MCQ live session and they take the benefit of it. Thank you so much. Thank you so much, guys, for watching this video. And take care. Again, let's meet on 21st for the last session of this week, 21st at 4:30 p.m. Take care. Bye.